Five, four, three, two, one. We are going live now.
I welcome all the faculties and participating doctors and the eminent faculties which we are having currently for the national panel discussion on managing psoriatic disease and beyond skin. So today we will be having eminent dermatologist Dr. Muralidhar Rajagopalan who will be moderating the session. Dr. Muralidhar Rajagopalan is head dermatologist at Apollo Hospitals, Chennai, and is practicing dermatology from last 30 years. His core interest areas are psoriasis, atopic eczema, immunodermatology. He initiated use of biologics in India. He is counselor at International Psoriasis Council. He is part of Education Committee and Regional Coordinator for Global Psoriasis Atlas. He has more than 7 orations and have delivered more than 250 lectures. He has also conducted more than 50 CMEs and more than 50 master classes. He has more than 40 international publications and he reviews 16 journals. So he's reviewer in 16 journals. Beyond academics, his interest is photography. So with this, I would like to hand over the dais to Dr. Muralidhar Rajagopalan. And for the betterment of audiences, there will be pre-poll questions and there will be post-poll questions as well, by which we will be able to know how beneficial the session was for the audiences. With this, I would like to hand over the dais to Dr. Muralidhar Rajagopalan. Thank you.
Thank you very much, Dr. Nitesh. And I would like to place on record my gratitude to Dr. Brijesh, Dr. Prakash, and Dr. Ramesh. Dr. Brijesh is a dermatologist. Dr. Prakash is a senior cardiologist from Mumbai, and Dr. Ramesh is from Bangalore. He's a rheumatologist. The rate of the purpose of this particular symposium is to look at how the treatment of psoriasis affects the comorbidities. And today we've chosen two important comorbid conditions of psoriasis, that is cardiovascular disease and joint disease. As you all know, there are several other comorbid conditions. And we will start with this. This is the beginning of trying to integrate multiple specialties, because merely talking about psoriasis as a multi-system inflammatory disease is not enough. We need to get the other specialists also on board so that we can have an open discussion as to how things are. I would like to request the administrator from Novartis to cut down the background noise because it's a little annoying. So please cut down the background noise, do something about it. Yeah, it got cut down. So there's something that's happening at your end. Please correct that, okay? Because otherwise I can't proceed with my discussion. So would you like to show the CV of Dr. Brijesh, Dr. Prakash, and Dr. Ramesh? Or shall I just go into the discussion straight away? Dr. Nitesh, you are supposed to do that.
Yes, sir. I will just reflect the. I will just brief out the CVs of sir.
Yeah, please do that, because please briefly introduce our panel. Once you introduce our panel, we can go ahead with the discussion.
Yeah, sure, sir. He's one of the eminent dermatologists, and currently he is practicing in Jaipur. So he has been there in the field of dermatology from last many years. He has a lot of research publications, as well as he has core interest in many research areas. And so we have a rheumatologist with us and one of the eminent cardiologists with us. So with this, sir, we can continue the session. Dr. Murali, we can continue.
All right. Now I need to get this poll out of my face. Please take out the poll.
Yeah,
Doc, go
just
to
press on the
slide
slide
area.
and you'll be able to get
Just click on
the
slide.
panel out then.
Fine. So this is the disclaimer from Novartis, but I must say that most of the slides have been designed by Novartis. Now we come to, for the sake of completion, we talk about the scope of the problem of psoriasis. Psoriasis is a global health problem with a worldwide prevalence, and the prevalence is increasing worldwide. In fact, we are just in the process of authoring an article where we found the prevalence to be almost 3.5 to 4%. It's a pretty high figure. And the unfortunate thing is that 75% of the patients experience an onset of disease before the age of 40. And it has been now recognized as an important chronic non-communicable disease by the WHO. And non-communicable diseases are going to take more lives than communicable diseases in the future, and it is important to target that. And you cannot afford to delay or interrupt treatment when it comes to a condition like psoriasis. All the more so because psoriasis is a multi-system inflammatory disorder. The panel doesn't require any education about what psoriasis is, but it is an immune-mediated inflammatory disorder which affects practically all organs in the body. The National Psoriasis Foundation set several treatment targets for psoriasis, and the preferred assessment instrument was the body surface area. The initial acceptable response after treatment initiation was a reduction to 3% of body surface area or 75% improvement after baseline. And we looked at 3 months after initiation of the treatment. The target response is to bring it down to less than 1% at 3 months after initiation of treatment. The target response during maintenance had to be maintained at less than 1% at 6 monthly assessment intervals. Now, the concept of treat to target in psoriasis has come in. This is important because if you see, psoriasis is a complex disease. It affects physically, psychologically, and socially. And we need strict protocols with the targets within the time frame. We need full, clear skincare pathways. Now, this is because it is a complex disease, you need a multidisciplinary holistic approach or an evidence-based approach to effectively treat psoriasis. Till now, practically all the lectures on psoriasis that have been done in the public space have involved only dermatologists, or lectures on psoriatic arthritis have involved only the rheumatologists who look at the arthritis part. But we need to understand it can affect multiple organs, and it's time to make psoriasis a multidisciplinary specialty. So we need also active participation by informing and educating the patient. And the reason for a multidisciplinary holistic approach is so that you can have a timely detection of comorbid conditions. We can refer the patients to the specialist and treat accordingly. And when you have a proper education of the patient, the motivation for treatment, the adherence, and to improve becomes better. Now, all of this translates into this green bar at the bottom that you see here. The fact that it is a complex disease refers primarily to the skin. The fact that you need a multidisciplinary holistic approach talks about the comorbid conditions. And the fact that the patient counseling helps him to get a better life refers to the health-related quality of life issues. So ultimately, we have this red box over here, treat to target approach for personalized medicine. So every patient of psoriasis does not necessarily have just now I don't know, actually this was different, but I think this people have trained. um, skin now can early treatment with biologics potentially modify the course of the disease. What are your views on the use of biologics as first line in psoriasis cases? Actually, this was supposed to be animated, but I think uh, these people have made a mess of it, but that doesn't matter. We'll start off with Dr. Brijesh. As you realize, this will be part presentation and part discussion so that we keep the whole thing lively. Dr. Brijesh, what do you feel? Because if you see that poll initially that they had put, we had about 70% of people who had mentioned over there that they are familiar with biologics. So, is it worthwhile to raise this question that can early treatment with biologics potentially modify the course of the disease? And what are your views on the use of biologics as a first line in psoriasis cases?
I think the biologicals as a first line is an emerging option for me more and more. Some of the indications where I can think about biologics is when there's an important ceremony coming up for a particular person, or he has got a professional requirement. So even a mild to moderate psoriasis, which affects the quality of life, will make me think about biologics. The second most important thing is psoriatic arthritis, which remains very high on the cards. Third is when there is some end organ attrition, like renal issues, which preclude the use of a systemic conventional DMARDs. So these are the three most important scenarios that I can think of. Like a severe nail psoriasis, a severe palmoplantar psoriasis, a severe facial and scalp psoriasis. That itself demands biology. Then obviously erythroderma, generalized pustular psoriasis. These are all indications which definitely will make me think of biologics.
Brijesh, you have given us some of the classic indications where biologics should be used as the first line. But if you look at what they have asked, is can early treatment with biologics potentially modify the course of the disease? So by giving the biologic, are you changing the course? This is a big
well, that is what I would like. That is what I would like to think. Yeah, because this particular question, we have to discuss a little bit of immunology. We have to talk about the molecular scar. That is the T-resident memory cells, which actually are there, and they are like the embers of the fire which are actually burning. So even a mild psoriasis or a moderate or a severe psoriasis has those embers. So I would like to believe that a biological intervention early on should change the natural course of disease and prevent this chronic inflammation and insulin resistance and the psoriatic march, as they say. But we do not have the solid evidence for that.
One thing I can add from my side, Dr. Brijesh, is that for this you really need a cohort of about 10 years of patients who have been started on a biologic and they've been followed up systematically and seen whether the number of comorbidities come down or they don't come down, and the course of the disease changes or doesn't change. So that's a slightly difficult thing to do.
And another study design, which I was just putting my mind to what kind of a study design can do this. We have a registry, something concept called registry-based RCT. A large simple trial within a registry with loose parameters, not a very tight parameters, with a margin of error. So that is one. The second option is something called Mendelian randomization, where you have an existing thing, but the problem is to select which genotype to select. This should not directly influence the outcome, but should influence the biological response. Now that's a tricky one. Some might thought process, if it goes into it, maybe we can come to some solution regarding the Mendelian randomization thing. So here you're not actually randomizing it; it's just a case control only, but with the Mendelian genotype differentiating the population.
over here,
two
Dr.
thoughts
Brijesh, one thing that we need to understand is that it has been shown that when you give infliximab, the blood sugar levels come down even within 2 hours of the infusion. Yeah, this has been
well, I am not aware of the
studied,
particular
it's been
phenomenon.
proven. And in fact, in diabetics, when they give infliximab, the sugar levels come down within 2 hours, and the requirement for insulin also tends to come down. So there are some early shoots coming up which show that targeting the immunology of the disease
Yes.
can actually modify the course of the disease. The next thing is, since I have a lot of work to do with the cardiologist and rheumatologist, do you really think that this treat to target is a reality or an aspirational goal? I just want a very simple yes/no answer because I'll take this to the cardiologist and rheumatologist also.
Yeah, definitely. I think the street to target is a definite goal which has to be achieved, because how often I've seen that psoriasis is neglected while we target just the cardiological aspects of it, and eventually land up with a problem which can go really out of hand. So yes, I do agree.
Yeah, Brijesh, what do you feel? Do you think it is a reality, a treat to target? Dr. Prakash has put down his views clearly.
It is a very altruistic goal, but practically it becomes very difficult because of the cost factor, the number of visits that is required, there is number of hours of work lost, the economics of it basically, and then there are some people who have got needle phobia also. So that
can I give an example of a patient who's currently admitted with pain?
I'll just come to you, sir. I'll come to you. There are some. Okay, but I want Dr. Ramesh to come in. Dr. Ramesh, do you think treat to target is a reality? I just want a simple yes/no based out of your practice, because we will be, Dr. Prakash and Dr. Ramesh will be expanding further.
Sure, sir. Good evening. Yes, I think from a rheumatological perspective, we have a treat to target approach to all diseases and definitely to psoriatic arthritis also.
Okay.
The one reason I'd like to give is it has been clearly shown that if you don't aggressively treat psoriatic arthritis in the early stages, the most important predictor of joint damage is the duration of the arthritis. So if you halve the duration of the arthritis with whatever treatment, whether it's biologics or non-biologics, based on affordability and other issues, the aggressiveness is more important than the agent. So treat to target in an aggressive early approach is definitely useful in rheumatological manifestations of the disease.
Now, Dr. Ramesh, if I can be with you over there, all of you have said yes, but I will just address this question only to you because I need only one response for this. You all seem to agree that there may be some sense in being aggressive in treating, but Brijesh has brought up the issue of cost. And the other problem is there is an attrition of response to a biologic as time passes.
So, as I was just saying earlier, the treat to target does not mean only a biologic.
Right.
So, there was this very beautiful study from Scotland called the TICOPA study, which is tight control in psoriatic arthritis, and they never used biologics there. It was the traditional disease-modifying drugs like methotrexate and cyclosporine.
Yeah, I'll come to that. We've got that included in our study. So that's all I wanted to hear from you. That while it may not be practical with the biologic all the time, even a traditional DMARD can help. Can I summarize it that way?
Yes, definitely.
Right. Now, any one of you could take this for aiming this. Let us say we have an idealistic situation where a patient can use the biologic. Now, do you face now? I assume, Dr. Prakash, that you are not directly using a biologic, but Dr. Ramesh and Dr. Brijesh are using biologics. So, do you face challenges with the biologics as regards opportunistic infections and latent tuberculosis reactivation? The reason why I asked this question is that recently in one of our dermatology forums, somebody had made a very cynical remark that if you use the biologic, it doesn't work. If you use the biologic, there is no cure. If you use the biologic, patients end up with serious systemic diseases. Now, so I want that to be put out of the spectrum of discussion straight away.
Okay.
So what is your experience? Because you're the guys who've been using it.
Sure. So if I give my experience, we have both personal experience as well as published data.
No, let's give your personal experience.
Our own data from Karnataka, we have something meticulously for latent tuberculosis, identify the positivities and treat them with the prescribed medications which are recommended by the WHO. The risk of tuberculosis is almost negligible. So I don't think the fear of tuberculosis should preclude use of biologics because they are such wonderful drugs. And eventually,
what about diseases like sepsis? Do biologics produce sepsis, Dr.
No. In my personal experience of almost 20 years of biologics, I hardly see pyogenic sepsis. I can even name him in one or two occasions.
Dr. Ramesh, no, you see, all of you will have to put up with me on one small issue, in the sense that I'm going to get the discussion going. So now over here, I'm going to ask you very, very specifically: do you see conditions like pneumonia and cellulitis with the newer biologics, like let's say the IL-17 blockers? Do you see that?
So far, no.
Excellent. Brijesh, do you see pneumonia?
Yeah, I have also had a very similar experience. I have not seen pyogenic infections and sepsis in my patients, which I do occasionally have with rituximab. I mean, that is one drug which actually, but let's not deviate from this discussion.
Okay, fine. What about latent tuberculosis?
No will be my answer.
No.
But what about
again? No, Rashford, I have had none, because I always because I like to add a point here. I'll always work up even a patient of psoriasis who is being planned for biologicals with both IgRA as well as MON2 test and the chest X-ray. These three are mandatory before they go in for the start of a biological. And if there is a discordance between the TST and the IGRA, I'll still go ahead and start the prophylactic ATT. So I'll err on the
positive
side.
Those confusions have been taken off. Dr. Prakash, Dr. Prakash Sanzgiri, now that you've heard from the rheumatologist and the dermatologist about their experience with side effects in using biologics and what to expect when you use a biologic, would a cardiologist like you be feeling happier to ask the dermatologist to start a biologic?
Absolutely. As a matter of fact, sometimes I repent not having done it for my patients in the past.
Right.
So, can I elaborate a little bit about one case presently admitted with me?
Yeah, please.
So this is a 42-year-old gentleman who came to me last week with a hyperacute anterior wall myocardial infarction, very high blood pressure, florid left ventricular failure.
Yeah.
I mean, he had undergone a bypass surgery 3 years back.
Yeah.
So we treated him with thrombolytics, and what we found that all his grafts, which were put before, vein grafts were blocked. His left anterior descending, which had no disease, diffusely diseased, that is within 3 to 4 years. Going back into the history, the clinical parameters that he has are significant psoriasis. And I asked him, he said, no, this psoriasis has come up very recently over the past 6 months. And I've been just looking at it. I've not been. He has a history of psoriasis before he underwent the first bypass surgery. Now, within a space of 4 years, significant deterioration is something which can be life-threatening, and this was life-threatening for this patient. So in such a patient who has got significant cardiac disease, I think treatment of psoriasis would be mandatory with the biologics if they're going to benefit, because it will also help his coronary artery disease.
Excellent. We will, of course, be giving you more evidence, sir, on that in the coming slides. And we will be also helping our audience to understand this further, because you have summed it up, but nevertheless, it's good. Now, when you look at this, we are concentrating today only on the cardiac problem and on the joints, but there are GI problems. There are neurological problems like depression, uveitis occurs in the eye, ankylosing spondylitis occurs in the spine. I'll be asking Dr. Ramesh about ankylosing spondylitis, though it's not there in the list over here. NASH occurs in the liver. Nail psoriasis, genital psoriasis, and palmoplantar psoriasis, Dr. Brijesh already mentioned. So these are all several of the issues which can come up when a patient has psoriasis. And you have what is called as a psoriatic march, which leads to comorbid conditions and irreversible changes. Now, over a period of time, what starts off initially as an inflammation due to a genetic predisposition or environmental problems, and then produces psoriasis or the psoriatic arthritis spectrum, leads to several other comorbid conditions like cardiovascular and psychiatric comorbidities. We know that psoriasis patients are next only to cancer as far as suicide is concerned. And of course, consequences on the quality of life. And there are habits like alcohol, smoking, problems with adherence, compliance to treatment, all of which not only produce psoriasis, but also become a result of the patient having had psoriasis. So these are all, ultimately it becomes an irreversible change. So this adds a lot of strength to the statement from our panelists that treating a patient aggressively right in the very beginning is going to help to prevent the irreversible changes from setting in a patient of psoriasis. Now, psoriasis is associated with a reduced life expectancy, and if you look at it, the absolute risk of cardiovascular risk is the highest amongst them. Infection occurs in psoriasis itself, not just because of the biologics. Please remember, these are not patients in whom biologics or methotrexate have been given. Even neoplasms, malignant neoplasms, most famously the lymphoma. Just today, I happened to see a patient in whom a squamous cell carcinoma had developed in a psoriatic plaque. He got the whole thing excised. So then you have liver disease, suicide, accidents. So there are a lot of problems, and this is a fairly large cohort study, 3,600 patients. Okay, so this is the point, and it was compared to 14,000 patients who did not have psoriasis. So the reason why we got Dr. Prakash over here is that cardiovascular disease conferred the top highest absolute and excess risk of death, and we would like definitely to avoid that. The risk of cardiovascular diseases increases with the severity of psoriasis. If you look at the severe psoriasis, the risk is highest. And when you look at mild psoriasis, the risk is not that high. So any comments from the dermatologist on this particular slide? Dr. Brijesh, are you there? In this slide, we have mild psoriasis showing you minimal risk and severe psoriasis showing you maximum risk. So,
yeah, mic is disabled. Can I just request, because this is a combined panel and speech this thing, so that the web stream people, please do not disable my mic, because I'll have to give frequent inputs. Okay. So there is this interesting study, I think by Arakawa, the guy, the York Prince group, which actually stated that the level of inflammation, both systemic and in the skin, is the same for mild as well as severe psoriasis. And a particular criticism of this particular slide, the graph which has been depicted, if you see, the vertical axis is stretched. So that makes it look as if there is hardly any risk in mild psoriasis, and there is a lot of risk in the severe psoriasis. I think it's a, I would criticize the vertical aspect of this particular graph. And let's not take the impression that there is no risk.
Great. Dr. Prakash, do you agree with that?
That's the input.
Even a patient with 1 or 2 patches of psoriasis, the risk of cardiovascular disease or stroke is as bad as somebody with extensive disease.
I look at it as a cardiologist from a different perspective. I look at it from a different perspective.
Yeah.
I think what they should have qualified here is those people with associated ASCVD, that is atherosclerosis score, which is high, low, and moderate. If they had done that, if the person has got diabetes associated with a mild psoriasis, that person is as much as a risk as a person who is with a very high severe psoriasis. So I think superimposition of risk factors for cardiovascular disease
Yes.
is very important in this to determine how significant this risk is.
Okay, thank you for the very clear.
I like to give a counter comment or add on to what he has just told. Whenever there is a trial which is being planned on a long-term basis, the baseline risk has to be balanced in both sides. Otherwise, you will get fallacious results. The baseline cardiovascular risk is
Okay,
the
I
most
must also
important factor
clarify
in these
to
kinds
all
of
my
studies.
panelists and to the viewers who managed to log in that these were not the slides which I gave Novartis. Novartis has changed them all. Okay, so I need to clarify that. So cardiovascular risk factors are under-screened and under-managed in psoriasis patients. I think this speaks for itself, where I think, Brijesh, you will agree that many of us dermatologists, when we see psoriasis patients, we don't actually look for the cardiovascular risk factors, and we will be reverting to Dr. Prakash as to what are the ideal risk factors that we should be screening for. So we'll be doing that in a few moments' time. And the increased risk of major cardiac events in severe psoriasis. This is once again just expansion of what was there in the earlier slide: cardiovascular death, then MIs, and then stroke. So this is from the American Heart Association. These are all the increased risk of major cardiovascular events attributable. And the comorbid conditions in patients with psoriatic arthritis seems to be much more than in patients with just psoriasis. Dr. Ramesh, I hope you will agree with that. Because in patients with psoriatic arthritis, cardiovascular disease, hypertension, dyslipidemia, and type 2 diabetes seem to be much more common than in patients with the plain psoriasis alone. A word from you, a simple word on that.
Yes, I definitely agree. See, the burden of cardiovascular disease is proportional to the degree of inflammation. We agree that in arthritis, the inflammation is severe. If you take the same analogy with other rheumatological diseases like lupus, like rheumatoid arthritis, it has been shown very well that even after correction for all the baseline Framingham risk factors, the classical risk factors, just inflammation per se is enough to increase your risk of cardiovascular diseases.
Great. So now, of course, once again, this slide is supposed to have been animated, because these are mainly, the questions which are for the cardiologists. So here, Dr. Prakash, you have mentioned a couple of things, but I would like you to just, we have only half an hour left. But briefly, what is the importance of screening for cardiovascular disease in psoriasis patients, and does it affect your treatment approach?
See, primarily the first thing is that we don't want cardiovascular disease in these psoriatic patients, whether they are young or old. So keeping in mind this particular aspect, the older generation, particularly male above 45 and females over 50, should be screened for all cardiovascular disease factors. This would mean history of smoking, hypertension, diabetes, dyslipidemia, obesity, metabolic syndrome. All these factors should be screened for and modified according to the need of the hour. That is the first.
So that's the message you are giving to the dermatologists who manage to log in.
Absolutely.
Great, sir. Now, the role of the pro-inflammatory cytokines, Brijesh, could you just tell us a little bit without taking too much time? Because I'm sorry, all of you are rushing because we are running short of time.
What I would say in this case is there are these four horsemen of the apocalypse, as I call them: IL-6, IL-17, TNF alpha, and IL-1 beta. I mean, these are the four things which are shared between the chronic inflammation of psoriasis and psoriatic arthritis, as well as the cardiovascular atheromatous flux. So I think in one word, these are the four horsemen of the apocalypse. So and they drive the inflammation forward. You can call them as the sparks in the fire. And if the fire is the chronic inflammation, the cytokines are the sparks, and the smoke which kills is the cardiovascular
So
disease.
I'll come back to you,
like
Dr. Prakash, if you could take the next two together, which talks about the essential clinical markers for assessing the risk of cardiovascular disease. And what are your views on the shared pathway of pathophysiology? This shared pathway of pathophysiology, you can take it in the next slide if you like, because I've got a slide for you. But essential clinical markers, because Brijesh has spoken about the cytokine markers, but clinical markers for assessing risk of cardiovascular. Because you see, sir, what we're trying to do is we're trying to get dermatologists to become a little bit more sensitive to assessing the risk of cardiovascular disease in the OPDs.
The first and foremost important factor which we have to keep in mind is to look for metabolic syndrome.
Yes.
Truncal obesity, abdominal obesity, because that is a place where the fat is bad. It's white fat, which is inflammatory fat. And if associated with psoriasis, you're going to have a volcano which is going to burst anytime. So those people who are obese, particularly those who have abdominal fat, these are the people who have visceral fat, and visceral fat is bad for the heart because there is pericardiac fat which can be inflamed and cause coronary artery disease, acute coronary syndrome. So look for metabolic syndrome, number one. Second, diabetes, usually high with people have got inflammation, coupled with psoriasis, it's a bad problem. Hypertension, usually not well controlled when the person has psoriasis because of the vasoconstrictive problems which occur with the cytokines which occur. And in addition to that, the stress which occurs with psoriasis, the psychological stress, is another important factor which really worsens this particular factor of psoriasis. I'm not talking about the other risk factors. Dyslipidemia is common with people who are psoriasis, particularly with certain drugs which are there. So you have to look for dyslipidemia and treat the dyslipidemia. So these markers which have to be assessed in all those patients who are at high risk, particularly in the people who have got severe or moderate psoriasis, or those people who are younger but who tend to have other comorbid conditions.
So in this situation, would you just expand on that atherosclerotic index that you spoke about earlier?
I'm talking about ASCVD. ASCVD is the atherosclerotic cardiovascular disease index, which is there, and it gives you scoring. What is the risk of the patient over a period of 5 years, 10 years of getting a myocardial infarction or cardiac death? So if you have this risk score, it is easily available as a calculator, and you can calculate the risk score. If it's a high risk score coupled with mild psoriasis, you have to treat that patient. You have to treat the patient with biologics. You have to control the psoriasis because that's where some of the cytokines are going to be released. In addition to that, I also want to say that in addition to cytokines, there are adipokines which are being released, and adipokines are equally bad. Particularly if those adipokines reduce adiponectin, which is a vasodilator and good for endothelial function. So reduction of that itself is going to harm the heart. It's going to harm the vasculature. It's going to cause endothelial dysfunction, progression of atherosclerosis, and plaque rupture and acute coronary events.
So, if I can summarize, Dr. Prakash has given us, as dermatologists, a list of other markers to look for when we assess our patients. So, when you are going to start your patient on a medication, you need proper risk assessment. Risk assessment can be done only with knowledge of what are the risks, and you need to find a proper method to assess that. And he has given you that, so we're grateful to you, sir, for that. We will be requesting you to elaborate on this slide because of the pathophysiology, because your entire thesis is based on this. So tell us more about this, sir.
If you see the right-hand part of the slide, you can see it's a vessel which is there. And this vessel on the one side is you have interleukin 12, which acts on the T helper cell and promotes the formation of atherosclerotic plaque, which grows. As it grows, it obstructs the lumen and causes angina and causes ischemia. On the left-hand side, interleukin 23 acting on the T helper cell 17 releasing interleukin 17, 22, and this can cause plaque erosion, endothelial dysfunction, plaque erosion, plaque rupture, thrombus formation, and acute myocardial events. Now, why is this important? If you see on the left-hand side, the similar pattern occurs when there is psoriasis. So when you have psoriasis, you get release of all these interleukins, you get release of tumor necrotic factor alpha, you get release of interleukins, which can cause problems not only in the skin, but they also cause problems in the coronaries and the vasculature. Now, when I say coronaries and vasculature, I mean to impress upon you that the incidence of strokes is also higher.
Yes,
so it is not only it's the strokes also.
Yes, we'll be coming to that. But I'm glad that you brought this out. We can see a similarity of cytokines. It's the same cytokines which affect the skin and the heart. So it makes a lot of sense to target the cytokines so that you can help to minimize or mitigate the risk of heart disease. Now, we talked now about the effect of psoriasis treatment in reducing this cardiovascular disease. This slide is of biological therapy versus therapy. I had asked for this slide to be retained because we find phototherapy is being used in a majority of our patients in India, primarily because of cost factors, because phototherapy is not very expensive, but it does not really reduce the risk of cardiovascular disease. This is a very large analysis of 11,000 patients on TNF blockers and 12,000 patients on who were on phototherapy. The patients who were on the biologic had a lower risk of cardiovascular events as compared to phototherapy. The risk of reduction associated with 6 months of cumulative exposure was 11% larger for patients treated with TNF compared to phototherapy. So there was a significant reduction, and even by the numbers you can make out that the reduction was significant if the TNF blockers were given. The p-value is not very significant. A lot depends upon this. So Dr. Prakash, if I may just ask you over here, have you seen patients who have been treated with TNF blockers?
I've really not seen anybody who has been.
No, I will understand because you are super specialized into cardiology. So please don't mind my asking this question. But have you seen patients who are on long-term TNF blocker? I just wanted experience. That's
all. No. I have not seen anybody. Most of the people I've seen are on phototherapy or on methotrexate.
Okay, we have slides on that. We'll discuss that.
Yeah. Most of the people are on these drugs. I'm very open about it.
No, we have
and looking at the data, it looks that
we are aware of that, and we have slides on that. Now we come to biologic therapy versus methotrexate in reducing cardiovascular risk in psoriasis, the long-term data. This was a study by Jashin Wu. He compared the major cardiovascular events between patients treated with biologics and methotrexate. As Dr. Prakash rightly said, majority of patients in India are on either methotrexate or phototherapy. But if you look at the TNF cohort, the major cardiovascular events, the percentage one is only about 2%, whereas the methotrexate cohort, the percentage is about 3.6%, which was significant. And similarly, the stroke or transient ischemic attacks were also significantly more in the methotrexate cohort, as was unstable angina and myocardial infarction. So the most significant effects were seen on MACE, were seen on stroke or TIAs, and on myocardial infarction. Unstable angina, though there was a reduction, it was not that significant. Now, the amount of time taken for a major cardiovascular event and cumulative exposure to a biologic, you can see over here that it takes time. It takes time. The TNF users had overall lower cardiovascular event hazards than the methotrexate users. So if you look at this graph, which is on the right of your screen, I have put it on full screen mode over here. So you can see it actually, it takes about 3 years, the hazard reduction is more than 50%. So the longer you give the biologic, the more the chances that you're going to reduce the risk of a major cardiovascular event. Now, important. Please, Dr. Ramesh.
Can I make a point here? Yeah, just a caveat here. The TNF inhibitors are known to cause, in the long run, weight gain, whereas apremilast and methotrexate are known to cause reduction in weight. But having said that, seeing all the trials, what I feel is that the anti-TNF action, the anti-inflammatory action of TNF inhibitors is overpowering that particular factor of weight gain, because the same consistent result has been produced in multiple trials now by the TNF inhibitor.
Okay, now this is what Dr. Prakash was talking about. Very recently in New England Journal, we had what is called as the third study, the cardiovascular inflammation reduction trial. So randomized double-blind trial because many patients ask us, isn't it, or even doctors, many of my own colleagues say, when I speak in a meeting on biology, they say methotrexate does the same job. So why the hell can't we just give methotrexate? So this is the problem which we actually face. This incidentally was not a company-sponsored study. The third trial is a randomized double-blind trial of low-dose methotrexate, 15 to 20 milligrams weekly, which incidentally is the same as what we use in India. It's not considered low dose in India. In India, I think low dose would be 5 milligrams. Correct me if I'm wrong, Dr. Brijesh. Or vaccine placebo in almost 5,000 patients with a previous MI or multi-vessel coronary disease who had, in addition, diabetes or metabolic syndrome, as Dr. Prakash rightly pointed out. The endpoint was MI, non-fatal stroke, cardiovascular death, and it was interestingly found. Brijesh mentioned some of these, except the C-reactive protein, the molecular markers that he did mention. He mentioned interleukin-1 beta, interleukin-6, and C-reactive protein. The issue is that methotrexate did not reduce the level of interleukin-1 beta, interleukin-6, or C-reactive protein, and did not result in fewer cardiovascular events than placebo. So methotrexate doesn't seem to be the answer. So I'll go to Dr. Ramesh now, because he has patients who have been given methotrexate for various purposes, much more than probably dermatologists. What do you feel, sir, when you look at a trial like this?
So just based on this, I would not conclude that methotrexate is not useful, because it has been
sorry to interrupt you. The question here is that, is it useful to reduce atherosclerotic events?
When I say not useful, it is basically in the context of atherosclerosis.
Right.
So I'll see, it has been very well shown that in rheumatoid arthritis, long-term use of methotrexate alone reduces mortality from cardiovascular diseases.
Right.
So this nobody debates. It's a well-accepted story. It's has been shown very well that methotrexate is a very good effective agent to reduce mortality in rheumatoid arthritis. The story to take it in psoriatic arthritis is, if you look back, actually, there are not very good trials of use of methotrexate in psoriatic arthritis itself. The treatment of psoriatic arthritis with methotrexate was an analogy taken from treatment of skin disease as well as treatment of rheumatoid arthritis. So, in fact, methotrexate was never tested as in a proper randomized trial in psoriatic arthritis. That's where there's paucity of data. That's all. But that doesn't mean that the drug doesn't work in atherosclerosis. Rheumatoid is being shown very well.
But do you? One second, I just want Ramesh to qualify further. Do you? I am with you on the same page that methotrexate can help, but do you feel, because we showed you the data that was presented earlier, do you feel that a biologic, if a patient can afford a biologic or take a biologic, it would help better than methotrexate?
Possibly, because the whole concept is about offloading inflammation.
Right. And you feel methotrexate doesn't offload inflammation as much as the biologic does?
Yeah. So one important aspect to understand is that the inflammation what we see in psoriatic disease is completely different from inflammation seen in rheumatoid disease.
Right.
Even the cytokines are completely different what you see in these.
I'm going to come to that. Okay, don't worry. Now, my only other last question to you would be, okay, fine, we'll just keep that for the last part. Brijesh, you wanted a small comment? Yeah.
See, I just went through the search study. I mean, went through it in detail.
Yes.
The problem with the search study vis-a-vis the CANTOS, that is IL-1 beta study, is that the baseline CRP of the population which went into this trial was low. So when the baseline CRP is low, the effect size will also be low. So the chances of getting a significant result reduce. That's why I said that baseline CV risk and the baseline cytokine parameter should be comparable between the groups. And you cannot compare CANTOS with CIRT because of this particular reason.
No, it's a good point that you made.
I mean, that's
we come
something
to
which
another
I had in my mind.
issue, that is flow-mediated dilatation. It refers to the dilatation of an artery when blood flow increases. The primary cause is release of nitric oxide by endothelial cells. To determine the FMD, the brachial artery dilatation followed by transient period of forearm ischemia is measured by using the ultrasound. I think Dr. Prakash will be familiar with all this. In the Karima trial, we looked at the effect of secukinumab, which is an IL-17 blocker, on flow-mediated dilatation, and they found a 1% increase in flow-mediated dilatation, which correlates with 13% decrease in the relative cardiovascular risk. Dr. Prakash, coming to you, very specific question. This 1% increase in the FFD, is it so significant to reduce the cardiovascular risk?
Can we go back to the previous slide? I think now basically this flow-mediated dilatation is a simple test used to measure endothelial function.
Right.
Okay? It is just simple endothelial function. What they do is they attach the cuff distally and they put the transducer of the ultrasound machine proximally. And here you can see on the left side is the baseline, where you can see they have measured, let me see exactly how much they have measured it. It is 4 to 5 millimeters, the artery. And after the release of the cup, after 45 to 60 seconds, it goes up to 5 millimeters of the artery. Okay, so this is the flow-mediated dilatation is 11%. All right, so 4.5 to 5, it's 11% dilatation. Now, this is in a normal artery. After giving nitroglycerin, it goes to 4.3. So we are talking about small arteries where there is a little bit of increase. Now, we have to go to smaller arteries. And these smaller arteries are coronaries. And there a significant is by just increasing the endothelial function by 1%, you are reducing the risk of coronary events. When I talk about coronary events, I'm talking about chronic atherosclerotic disease and I'm talking about acute coronary syndromes both together. So that itself is going to contribute, and it is not going to be 1 day or 2 days, it's going to be over a period of time. That is the most important thing. So over a period of 5 years, you're going to get significant improvement and significant benefit to these patients. So that's what they say. It's endothelial function which you're measuring. In addition to this flow-mediated dilatation, there is one more index, that is low flow-mediated constriction. It has not been done in this study, but that's another index which is measured, which will also tell you endothelial function.
So you feel that this does make a difference, because their conclusion is that it produces a 13% risk, the decrease in relative cardiovascular risk. You think that
this is a relative risk reduction. It is not an absolute risk reduction.
Exactly.
So that's why it looks big. It is a relative risk reduction.
Great.
So if you can see here, it is 5.1, 6.3, that sort of a thing. So if it is just about 1% change, so it is a significant change. It's a relative risk reduction, and this is addressing residual risk in these patients.
Thank you, sir. Now, this is the effect of biologic in coronary artery plaques. One study Let me just, yeah. This is by Aina Bavi in Journal of Cardiovascular Research. Biologic naive patients were recruited. All patients underwent coronary computed tomography angiography at baseline and 1 year later so basically they were looking at the high risk plaques. The researchers observed reduction in non-calcified plaques across all three classes of biologic in the study with varying degrees. So the change in the coronary plaque burden, they found a 5% reduction in the non-calcified plaque burden on TNF therapy, 2% on IL-12 and 23 therapy, 12% in IL-17 therapy after 1 year. Now, this is where I would like to get Dr. Ramesh's opinion again, that they seem to be assuming that there is a change in the coronary plaque burden at the end of the year. But if you look at it, if you look at the pathogenesis that you showed earlier, where IL-12, IL-23, IL-17, TNF-alpha were all involved, the reduction was only 5% on TNF therapy, 2% on IL-12, 23 therapy, 12% on IL-17 therapy after 1 year. Is this enough to justify giving a biologic on day one?
I don't think so.
I'm going to appear like a devil's advocate now, please.
Yeah, I don't think so, because whether this translates into clinical benefit is unknown.
Right.
So whether this amount of plaque reduction at 1 year is going to cause a reduction in the cardiovascular event at 5 years, say, we don't know. So I think this is an exciting pathophysiological process of the drug.
Right.
Has been shown, but this should be kept in mind when you choose your patients. But this may not be the sole reason to pick the drug.
Great.
So can I refute this argument?
Yes, please.
See, this whole thing about plaque burden, necrotic core plaque burden has come from studies with rosuvastatin. Statins therapy was shown to reduce the plaque burden and reduce the plaque progression, and therefore over a period of time it has shown to reduce the risk of acute events and cardiac deaths. So this is an extrapolation from that level.
Correct.
What we are talking about is a hypothesis generation where reduction of this will reduce a lot of events. It will reduce the plaque rupture. Plaque rupture because of the necrotic core, MMP release, erosion of the plaque, the fibrous cap, and acute coronary syndrome, which can cause sudden death.
Right.
So extrapolation of the rosuvastatin data has been used here to try and prove this particular concept.
Thank you, sir, because this is the lipid-rich necrotic core that we are talking about. I put that up. And the effect of biologic in coronary artery plaque, there's one more study where it was done at the NIH. They chose 209 biological naive psoriasis patients. 124 received biologic therapy, both anti-TNF and IL-23 and IL-70. 85 were treated with topical systemic, conventional systemic and light therapy. They did the calcium score, and they found that the lipid-rich necrotic core was positively associated with male gender, hypertension, Framingham risk score, and PASI scores. So, would you comment on this, Dr. Prakash?
No, it is telling you the same thing. Absolutely a similar thing. They're telling you that use of these biologics can benefit the patient, reduce the plaque burden, and reduce events. So, eventually, what I again go back to what I was talking before. A person with mild, moderate, severe psoriasis and a high ASCVD score should be given the benefit of biologics rather than giving methotrexate or phototherapy, because it will not only help his psoriasis, but it will also help his other parameters in the coronary vascular tree. So that's the moot point of all these studies. It is not that every patient you should be giving biologics, but those people with high ASCVD risk score, whether they fall into the mild, moderate, severe group, should be given biologics. That's the way we should look at it.
Okay, sir. I'm going to ask you to summarize your recommendations after 2 slides, because many of the dermatologists will want to look for a summarized become a cardiologist. Is that all right? Now, the effect of biologic therapy on necrotic core of 1 year, they have shown that after 1 year there is a significant reduction. So this is what you were saying, that it could reduce it, but there are other factors also to be considered. You won't be using just this alone, but it seems to be giving you the science behind it. Now, can biologics play a preventive role in coronary artery diseases other than conventional agents? Now, this is a very dicey question, Dr. Prakash. I totally understand. Because the question is worded as biologics in psoriasis. Can you use this to prevent coronary artery disease?
So I would like to use
summary of whatever we discussed so far.
Yeah, I would like to use the example of other drugs which we are using, like PCSK9 inhibitors for reducing cholesterol in high-risk patients. We use it because those are high-risk patients. Coming back to the same thing, I'm coming again and again, in high-risk patients, definitely use of these drugs will benefit in preventing coronary artery disease. So we should keep this in mind. Again, going back, you talk about the risk, you talk about the metabolic parameters, and then use the drugs, whichever group of drugs. Yes, but those people who have severe psoriasis, where there's going to be an enormous amount of skin plaque burden, definitely these drugs will be having a beneficial effect.
Right. So then the other summary point that we need from you is we have discussed a lot of clinical data on biologics relating to cardiovascular comorbidity. What would be your take-home message from all this data that we discussed so far?
I'm sorry, I didn't get the last question.
We are just asking you to summarize your perception of the data on cardiovascular disease discussed so far.
Okay, the first and foremost, both psoriasis and atherosclerosis are inflammatory disease. Number one, psoriasis compounds the inflammation in the body and worsens atherosclerosis. That's number two. Aggressive treatment of those people who have atherosclerotic heart disease and psoriasis is a must. It will prevent acute events, it will prevent deterioration of the patient, prevent progression of the disease. More important thing which is there is that certain drugs which we are using in people who have got atherosclerotic heart disease, like beta blockers, can worsen psoriasis. So keeping this in mind, you have to be careful in the use of beta blockers for people with psoriasis because they're commonly used drugs for atherosclerosis. Do not underestimate the severity of problem which can occur because of psoriasis.
So coming to that, we cannot underestimate the severity of the problem. So we have a last question over there. Do you think that if psoriasis, now you must have seen a lot of, to be very frank with you, sir, in our country, we have only about 1%, less than 100 dermatologists who are using biologics for treating psoriasis. But there are patients coming to you for cardiovascular events on a regular basis. And you must have seen psoriasis in some of them. The question is once again, what is your perception? Is your perception that the burden of cardiovascular disease is more if the psoriatic patient gets suboptimal treatment?
Sir, I don't think that we have seen that many patients to have a personal view, right. Okay? But I can tell you is one simple thing. This symposium has changed my outlook towards looking at psoriatic patients. One problem which is there, which I have been virtually mistaken, is psoriasis of the nails. Yes. More often we are diabetics and we are talking this is fungal infections. We have been misled into this part. I want to, whoever physicians are watching, do not neglect this particular form of psoriasis because it's not very obvious. And in the long run, I think we have to be careful and look for, like we were in the past, we're talking about rheumatoid arthritis worsening or cystic lupus worsening cardiovascular disease. We have to look into the fact that psoriasis can worsen cardiovascular disease. We have to look at it in that perspective. And psoriasis with arthritis is worse than psoriasis alone. So that's a take-home message for cardiologists and physicians who are there. We have to keep this in mind.
Great, sir. Maybe if we have another program, hopefully we could go more in detail about the various biomarkers that you would recommend for assessing cardiovascular disease. The only one thing I'd like to ask you is it wise for a dermatologist when he sees a psoriasis patient to look at the HSCRP?
I feel that HSCRP is elevated in most patients with psoriasis.
Yes.
So I don't think it's going to be a marker which is going to be useful. But I would look at it from another viewpoint. Maybe ST2 levels can be considered. That's another marker. But again, that is not hard. A marker which will tell you whether there is associated disease of coronary arteries. It will tell you whether there's fibrosis or no fibrosis in the heart. So HSCRP is not worthwhile because most patients with psoriasis have HSCRP elevation.
Okay, sorry to keep you on. I know that we are taxing you quite a bit. I'm very sorry. But the discussion is getting interesting, and so I thought I'll just ask you two simple questions. One is carotid artery intimal thickening by ultrasound. Would you recommend that?
I think that's a very good question.
Not expensive. Dermatologists can get it done.
Yes, it is a very good test which is usually neglected. Yes. Neglected because our people in the ultrasound department don't spend enough time. It is not just showing that there is a plaque or no plaque. You have to show the magnitude of the plaque which is there and the flow which is restricted over there. It is an extremely good test which is there, as is the other one which we're talking about, the brachial flow index or other tests which are there for endothelial function. It's a simple test which can be done, but the person who is doing the test, the ultrasonographer, should be a person dedicated to do this. Unfortunately, that does not happen.
Hopefully, sir, in tertiary care centers, we will have it. And
sir, I'm at the tertiary care center and I face the problems without in the tertiary care. And I'm head of department of cardiology there, and I'm facing that problem every day. So sorry to say that.
No, 1 second, Brijesh, I'll come to you. Because
I just had a query for the cardiologist.
Too much because I've taken out so much from it. So one last thing I have to ask you is, now is it worthwhile to look for the calcium index? Because Nihal Mehta did that in Texas, in Dallas, for all his patients. He looked at the calcium score and showed that there was a reduction when they gave a biologic.
Absolutely, calcium score, coronary calcium score will be an index of coronary inflammation. And basically, coronary inflammation is what causes coronary atherosclerosis. If you have a high coronary calcium score, you can be sure that there is coronary atherosclerosis, but it doesn't tell you whether it is severe atherosclerosis or mild atherosclerosis. It just tells you it is a healed plaque. Like in psoriatic skin, you can get calcification. In coronary also, you can get calcification, and that's a healing process which occurs due to inflammation in the coronaries.
Thank you, sir. Brijesh wanted to take you.
Yeah, I just wanted to ask, there was this particular literature which stated that the femoral artery ultrasound will be a better parameter.
Femoral ultrasound has got a very different pattern and it is not considered anyway like a carotid edema media thickness. It is not considered in any textbook of cardiology or any journal. There are other tests which are coming about which are measurement of the myocardial or pericardial fat. The fat attenuation index. This is another thing. Again, you require a dedicated machine for that with very high resolution CT scans, which will tell you whether there is inflammation of the fat around the pericardium. That's a very good test because that tells you whether there is bad atheroma on the. So this is called fat attenuation index or the pericardial fat.
Great, sir. Wonderful inputs from you. Until we reach the end of the program where we will ask you to give us your inputs again. We are transitioning now from cardiovascular disease to psoriatic arthritis. That is Dr. Ramesh's baby. Psoriasis, there is a preclinical phase of psoriatic arthritis. Of course, that is manifested by the enthesitis. There is a subclinical phase which is very silent, where you can see only soluble biomarkers or musculoskeletal changes visible by imaging. We have prodromal psoriatic arthritis with arthralgia and fatigue, and classic psoriatic arthritis, as we all know. So the recognition of psoriatic arthritis requires a collaboration between dermatologists and rheumatologists. We have the clinical aspects. We will be showing you one of the questionnaires that is used. There are many questionnaires, as Dr. Ramesh knows, imaging and laboratory studies. So to optimize the role of the dermatologist and the rheumatologist, the dermatologist needs to confirm the psoriasis in a patient with inflammatory arthritis. The rheumatologist needs to confirm the reverse, that is inflammatory arthritis, in a patient with psoriasis. The dermatologist needs to optimize the control of cutaneous disease. The rheumatologist optimizes control of joint disease. The dermatologist has a duty to screen for psoriatic arthritis in the at-risk population. The rheumatologist helps you to utilize the imaging optimally. Now, hello?
The connection is cut.
Yeah. So where both work together in monitoring compliance, monitor for adverse effects, and screening for the other comorbid conditions. So when we talk about nail psoriasis, we are wondering whether this is actually a form of enthesitis which affects the distal interphalangeal joint, and is this an early marker of DIP arthritis and psoriatic arthritis? One of the screening tools is a test where you have a scoring system. You score for each of these, whether you have a swollen joint or joints, whether a doctor has told you that you have arthritis, do you have fingernails or toenails with holes or pits, and have you had pain in your heel? Have you had a finger or toe that was completely swollen and painful for no apparent reason? Each has a yes or a no. A score of 3 or more out of 5 yeses is a positive and indicates a referral to a good rheumatologist. So, Dr. Ramesh, this is your baby entirely. In a known psoriasis, okay, I'll take this to Brijesh first. Dr. Brijesh, in your psoriasis patients, do you have any predictor for psoriatic arthritis? And then I'll get Dr. Ramesh's input after that. Dr. Brijesh?
I don't see him on the screen.
Okay. Dr. Ramesh, we'll just go to you straight away. So what in psoriasis patients, what do you look at? Dr. Ramesh, what do you think are the predictors of psoriatic arthritis in our psoriasis patients?
So it's extremely difficult to give clinical predictors because that's what we want.
Yeah.
We should remember two important things. That in a proportion of patients, psoriasis predates arthritis, and in a proportion of patients, arthritis predates psoriasis.
Yeah.
And in a few of them, both of them are there. And the psoriasis severity could be anything from mild to severe. It doesn't necessarily mean that patients with the most severe skin disease should have joint disease.
Yeah.
So even those with subtle skin disease could have joint disease. Right. So the only predictor that has come up is nail psoriasis, as you pointed out earlier.
Yeah.
But other than that, we have no clinical predictors. So it becomes mandatory at least to have a quick ask for patients for history of joint pains, for history of swollen fingers or digits, for history of pain in tendon insertion areas, or an inflammatory back pain. These are 4 mandatory questions. Leave alone all the various screening tools cannot be practical in busy OPDs. But at least these 4 important questions are most important when you see a patient with skin disease.
Dr. Brijesh, you were trying to say something?
Yeah. The 3 particular phenotypes of psoriasis which are associated with psoriatic arthritis are nail, scalp, and genital. These are the 3 spots which are likely to be missed very easily because these are the hidden spots, as you say, or people don't examine. And there is also a tendency of over-labeling an arthritis, seronegative arthritis as psoriatic arthritis just because of any particular skin lesion. I have seen cases who had nummular eczema, classical nummular eczema, biopsy proven, but has been undergoing treatment as psoriatic arthritis for a long time because of the fact that they couldn't actually label it put in the proper classification, so that particular batch and label it as psoriatic arthritis. So that also, overcooking, undercooking. Both sides are have to be brought into mind. Yeah.
Dr. Brijesh, what about intergluteal psoriasis?
What's it, sir?
Psoriasis in the gluteal cleft.
Absolutely. Scalp, gluteal, perianal. So these are the areas that are most likely to be missed anyway. And many a time when you see this particular plaques, people diagnose it as tinea, that is dermatophytosis.
Okay, Brijesh, while you're still there, what are the screening tools that you use in your setup for psoriatic arthritis? Because it's in the derma setup.
Basically, some leading questions. PEST score is the one which is the most easiest and has got a good high sensitivity, specificity, and you can easily administer it yourself. There are only 5 questions there.
Right.
So I think it is easy. That can be implemented in our clinic. There is another questionnaire called ERP. There is another questionnaire called TOPAS-2, more elaborate. But I think PEST can be on your desktop. That is a particular printout of that particular thing can be under your glass, and you can just reel off those questions to the patient yourself and come to a conclusion.
Okay, Dr. Ramesh, now I want to ask you, do you think that we could have much better screening tools in the derma setup before we refer a patient to you?
See, primarily, as far as screening tools are concerned, like what Dr. Brijesh pointed out, you have to have a minimum questionnaire screening tool.
Yes.
You have a very elaborate one. It could probably suit the requirements of a private clinic, but it will not suit the requirements of a government medical college or a very busy practice. So that's why I said you have one question targeted at each of the 5 domains of the disease. Because psoriatic arthritis, unlike rheumatoid arthritis, has many various clinical domains. So that's why I said joint pain, any tendon insertion pain, a swollen toe or a swollen finger, back pain. These are, most important questions that, very simple, important questions. Or you can also ask, have you been on any painkillers for treatment of any pain? Because what happens is, many times patients think that talking about pain is not something that the dermatologist might be interested. He's only interested in the skin. That is the patient perspective. That, they may not want to come outright and tell a dermatologist that I have pain. So they will only discuss the skin part of it and leave out the joint pains. So that's why we might have to ask the direct question.
Dr. Ramesh, any laboratory parameters that you feel the dermatologist should do?
See, laboratory parameters are very tricky in psoriatic arthritis because the commonest type of psoriatic arthritis is oligoarthritis.
Right.
And when in oligoarthritis, very rarely will you have a raised inflammatory marker like an ESR or a CRP.
Right.
So it's been shown very well that CRP will be raised only in about 40% of inflammatory diseases. Okay. Right. So you can't rely solely on that. Also, in rheumatoid, it's easy because you have rheumatoid factor, anti-CCP antibodies, so on and so forth. Whereas there are no autoantibodies in psoriatic disease. And the only one test, which is HLA-B27, is barely positive in about 25 to 30% of patients with arthritis. Right. So that's why still psoriatic arthritis becomes a clinical diagnosis, and sole lab or any other things should not be used.
And your impression about various imaging studies?
Yeah, I was going to come to image. That was I said finally. Yeah. So by the time imaging findings come up, that is, for example, an X-ray change for psoriatic arthritis comes up, you've already lost a good few years. Right. Because what you see on an X-ray, you see enthesitis, enthesial calcification, bone erosion, bone damage. I mean, these are all end-stage changes. So ultrasound, musculoskeletal ultrasound is a good marker of early inflammation, but non-availability in most hospitals and the expertise required in musculoskeletal ultrasound is a big limiting factor.
Okay. What about these bone scans, these nuclear bone scans?
I would not do them.
You wouldn't do that. What about MRIs?
So MRI would be helpful only when you're looking at spine disease,
right?
Because MRI is a very good tool to pick up very early spinal disease, because that's spondyloarthritis is one such, another end of the spectrum of the disease.
Right.
So definitely an MRI would be worthwhile. If you want to screen very limited, you could just ask for a sacroiliac joint MRI and particularly ask for only a few sequences that has a T1 and a T2 stir. That's all you have to specify to the radiologist. And you will pick up sacroiliitis in those with the symptoms that are consistent with inflammatory pain.
So now I'm going to come to, no, there are only 2 slides because Novartis has taken off many of the other slides that we had. And one of the slides was Dr. Prakash's slide also. So we have only 2 slides left. So I think it is worthwhile for me to just ask you to explain a little bit more because we have about a few minutes left and there are no questions either from the audience. Maybe the audience couldn't log on because the link was the wrong link. But at least amongst ourselves, what is your view? You had started talking about your view about the pathogenesis of psoriatic arthritis. How different is it from the pathogenesis of psoriasis?
How different is it from? Sorry?
The pathogenesis of psoriasis per se.
Okay. So there is a different thought. Yeah. There is this concept of something called cytokine hierarchy.
Right.
So if you look at the whole spectrum of diseases, which are say B27 mediated, you have psoriasis, you have psoriatic arthritis, you have spondyloarthritis or ankylosing spondylitis,
right.
You have uveitis, you have inflammatory bowel disease.
Yeah.
You look at the various manifestations, the dominant cytokine may be completely different in each one of them. And that also explains why in an inflammatory disease like ankylosing spondylitis, for example, where TNF-alpha inhibitors, both etanercept and infliximab works, also secukinumab works, the same 2 drugs, that is secukinumab as well as etanercept, does not work in inflammatory diseases, nor does it work in uveitis. So this is something called cytokine hierarchy. And also if you look at data like ustekinumab, for example, IL-1223, it may be a good drug for the skin, but it may not be the best drug for the joint.
You know,
the dominant cytokine concept is there.
You know, Dr. Ramesh, one of the charts I had put up, which Novartis deleted on their own without asking me, I should have had the decency to ask me, was this Belgian study. They had the Belgian guidelines, which were just released about 2 months ago, in which they spoke specifically just about what you're mentioning now. Which type of comorbidity, which biological is most effective, which is least effective, which conventional is effective, the whole works were there. So I'm very sorry I'm not able to share this with my audience and you. But
can I ask a query here?
Brijesh, there's one more important thing I need Dr. Ramesh to clarify. Dr. Ramesh, the dosage of secukinumab for psoriatic arthritis is much lesser than the dosage for the skin. Is there a reason that has been given to you? Because when we look at it, we are not given the reason.
No, it's never been given. See, likewise, the dosage of infliximab given for psoriatic arthritis is different from rheumatoid arthritis.
Right.
So these were dose-finding studies which were done.
Right.
And in fact, I did the first study when I was in England on in ankylosing spondylitis by using the rheumatoid dose of infliximab for patients with ankylosing spondylitis, even though the dosage recommended was much higher, and found that a proportion of patients still respond.
Yes.
So, because cost becomes a big factor when you look at 300 milligrams of secukinumab.
Yes.
For cost reasons, to offset the cost, we are still using 150 milligrams, and we do find a good benefit in arthritis, especially.
Now, do you find any differentiation in the benefit of arthritis, peripheral arthritis versus central arthritis?
Yes. See, even when you come to peripheral versus central arthritis, even here, the consequences are almost the same because it's enthesial disease where in both the places.
Right.
But the consequences can be more devastating in both the places: peripheral destruction causing deformities and spinal fusion.
Right.
In terms of response to therapy, it's equally good. With most anti-TNF inhibitors, the data as far as secukinumab is concerned is more strong for peripheral arthritis than psoriatic spondyloarthritis, because the trials had few patients with psoriatic spondyloarthritis in them. Whereas secukinumab has been shown to be very effective in ankylosing spondylitis. So I assume that it should work in psoriatic spondyloarthritis also.
So you do not subscribe to the view that secukinumab does not work that well in an ankspond type of psoriatic arthritis?
No, I don't. Because we know that it works in all the other manifestations.
Right.
So I assume just because the trial had, the sub-analysis had only a few patients of spondyloarthritis, it doesn't mean
it was not a representative trial.
Sure.
That's a simple way to put it, right?
Yeah.
There is no difference in the pathophysiology between Angst-Pont type of psoriatic arthritis and peripheral arthritis. Both are enthesitis.
Both are enthesitis, but the dominant cytokines are different.
So
that's why
dominant cytokines are different. Shouldn't it make a difference when you are using just a very, very targeted drug like secukinumab?
Exactly. So that's why we now know in biologic therapies that we don't have biomarkers to choose biologics. So when you actually look at, when you have a whole lot of biologics sitting in front of you, we all know that some patients respond to secukinumab, some respond to adalimumab, and some might respond to infliximab.
Right.
But which one should we choose for a given patient? Nobody still knows the answer.
So that is something which is left out, right?
Yes.
Okay, Dr. Brijesh, you wanted to raise a point?
Yeah. Is it true that psoriatic arthritis is more towards the IL-12 axis and psoriasis is more towards the IL-23-17 axis?
Yes.
Do you feel so?
Yes.
Okay, Brijesh, when it comes to counseling your psoriasis patients, because we have had the good feedback from the rheumatologist and the cardiologist. So after this, would you change the way you counsel your, as a dermatologist? I mean, I'm also a dermatologist, both of us are dermatologists. Would we change the way we start counseling our patients?
I mean, the one good input that I received was the ASCVD score. I'll definitely incorporate that into my screening systems. The first counseling for a biological is very important. It takes time. Most of the times what I do is that I admit the patient, so I can spend time with them. In the morning, the first thing I do is that the guys on biology, they come to me and they say,
and working for Apollo hospitals or
so what I do is I give them a good lifestyle advice, a good infection control advice. I give them a instruction pamphlet in which has got Hindi, English, or worse, because infection and hand hygiene. And thankfully, one good thing that COVID has contributed to the Indian milieu is the better hand hygiene and the mask wearing. So I think our biological patients are much more safer now than before. Frequent hand sanitization. Lifestyle modification, you have to very much stress in the initial particular screening. More so than that. More so than that.
When you talk about lifestyle modification, can I qualify it and say that you will advise lifestyle modification in order to mitigate or avoid metabolic syndrome? Because Prakash was very clear about the fact that metabolic syndrome is going to increase the risk of cardiovascular.
Correct. And one more thing is that obesity per se itself can cause incident psoriasis. We are always thinking of it as an association. Now we know that these are the counseling. And one more thing which I wanted to convey to the audience is never underestimate the paying power of a patient in a private setup. Because many a time they are so motivated. This has been told me by a private practitioner. I don't have private experience regarding this particular facet of it because our patients don't pay. If you tell them that these are the options, lay the options in front of them. This is the cost, this is the thing, this is the cost. I know one rheumatologist actually giving a lot of relief to psoriatic arthritis patients using just etanercept 25 milligram fortnightly, along with a conventional DMARD, because that's all that farmer will be able to afford.
Yes.
And 4,000 rupees in a month, but at least you have to lay that option. You will be surprised to know that many of the people will actually take that option. Just looking at a particular patient, don't think that he is not qualified for biology. That's not the criteria.
Now, towards the end, what I want to ask you, Dr. Brijesh, before I go to concluding remarks from Dr. Prakash and from Dr. Ramesh. Dr. Brijesh, the point is that we have got data which show that there is some attenuation of risk of cardiovascular disease by continuing biologics over a period of time. At the same time, I think you will agree with me because I have seen it in my practice. I've used biologics for 20 years almost now. There is definitely every single patient, there is an attrition of response over a period of time. And some of them, especially with secukinumab, I find that the new plaques and the disease starts coming back even in the 7th or 8th month of therapy itself. So how do you reconcile this?
Yes. I really don't know. I mean, there is not enough data out there to tell us why this is happening. I think this must be something to do with plasticity.
No,
I mean, the TH17.
No, I'm not asking you for the molecular mechanism. The reason why I'm asking you this question is that, if you are going to go gung-ho about using a biologic based on a very, very tenuous argument that cardiovascular risk is reduced. But at the same time,
I'll wait for longer duration trials before I can objectively state something.
Longer duration trials, I can tell you, the secukinumab, this Andrew Blobel did a long duration trial. He did the trial for 5 years. The same patients which he used in the erasure and fixture studies, he continued them on secukinumab, and he found that the attrition of response was as much as 40 to 45%. That was very, very big attrition of response.
Is it something to do with the downstream versus upstream thing? Are we going too close to the bush and missing the tree? I mean, that might be one of the reasons.
I certainly think so. But the point is, when it talks about counseling, this is what it makes the difference. Because what are we going to finally tell our patients, right?
Yes. Yes.
Can I ask one question here? Can you, in particular, see, this is very interesting what you tell me, because if there is attrition, then you're going to get increased inflammation. One possibility is that it could be antibodies developed towards this drugs which are there. There have been cases which they have shown antibodies. So whether that is that, then in which case do you give interrupted therapy?
You see, the problem is that with interrupted therapy, the chances of developing antibodies is higher. Now, for IL-17 drugs, they initially started talking about the fact that even though neutralizing antibodies develop in 4 to 5% of cases, they do not affect the response to therapy. We know that that is patently false. It's not true. It does affect the response to therapy. The third issue here is that if we give a lower dose of the drug, it does not work as well as it should. The fourth issue over here is that many doctors have been combining methotrexate along with the biological to think that the low dose methotrexate can prevent antibody formation. Once again, purely based on conjecture, not on science. We have not shown, because the company doesn't release data on antibody formation. But attrition of response is certainly there. I'm sure the rheumatologists have seen it, all the dermatologists have seen it. So what you are is very important, because if we are going to counsel our patients and take into account that over a period of time, using the biologic and that biologic as a first line of treatment, and you are likely to develop less chances of cardiovascular complication. But at the same time, we say that there is attrition of response. It becomes difficult to reconcile it. Dr. Ramesh, you wanted to say something.
Yeah, I was just talking about the anti-drug antibody story.
Yeah.
I think that the maximum anti-drug antibody story went with infliximab because it was a mouse-human chimeric molecule.
True.
And with respect to infliximab, it was beautifully shown that you combine it with moderate to low doses of methotrexate, you can prevent the incidence of HAC antibodies.
Yes.
So the same concept has been extrapolated into a variety of other indications.
Yes.
Even though anti-drug antibodies were shown with etanercept, it did not show clinically translate into reduced efficacy. So the story is not as simple as we assume. But from a clinical practicality, there's no harm done in combining methotrexate for two reasons. One, yes, the theoretical possibility of reducing antibodies. Second, if you have two drugs that work with the same goal, you could probably use a lesser dose of biologic and it could be a cost-effective measure. And that is what we do in rheumatology. We combine methotrexate with most of our biologics because that would have
bring out
using a smaller dose of the biologic.
What I wanted to bring out because though there are no hard studies on IL-17 blockers with methotrexate, people are using it, and there does seem to be some logic to it. But it would be good if we could measure these antibodies to have a more scientific way of introducing these antibodies.
A combination, sir, I would like to make a point. A combination of therapeutic drug monitoring and anti-drug antibodies will be the only way that we can answer this particular conjecture. Unfortunately, it is not available at any level. To us. I don't know about the rheumatologists. Are you using therapeutic drug monitoring and anti-drug antibodies? This has to arrive in the market. This has to arrive in the market. At least in the cases of secondary failures, primary failures obviously will change the particular molecule. In case of secondary failure, you need to know why. And currently, we are not able to answer why.
Okay, I'll go to Dr. Prakash to get his concluding remarks about cardiovascular morbidities. So, could you give your concluding remarks? Because there was one slide you wanted, it's not here. But tell us offhand, what do you feel, given all this data? You had 1.5 hours of discussion.
I think it's a wonderful discussion, which was very enlightening to a cardiologist like me, because believe me, I really knew nothing about psoriasis before that. Few things which I would like to stress about is, let's keep in mind that the longer the duration of psoriasis, the more chances of the person having coronary artery disease. The second is psoriasis is commonly associated with metabolic syndrome, diabetes, hypertension. One should look for it in all patients with psoriasis, particularly over the age of 45. The third is, think in terms of evaluating person for coronary vascular disease, even in those people who have mild, moderate psoriasis, if they have a high ASCVD risk. The fourth, which is very important, is yes, one would like to give biologics subject to the fact that the patient is going to continue them for a longer time. If the person is going to stop them after a few days or a few months, it doesn't make sense to give them. It's rather better to use other drugs in the long run. And at the end of it all, as a cardiologist, I feel that it's costlier to get a coronary bypass surgery than to use preventive therapy like biologics and drugs like statins in the prevention of cardiovascular disease and psoriasis. It is much more costly and much more traumatic and much more socially incapacitating for patients to go for a coronary bypass surgery or an angioplasty. So these are the small points which I want to make and keep in mind.
Any word about strokes?
So very frankly, this is one area which is really, I don't think many neurologists really want to talk about it. And I've not seen this happening, but I would keep it in mind when I see the next psoriasis patient to get a carotid Doppler. I would definitely
Thank you so much. Thank you so much for your comments and enlightenment. It was very, very useful for us. But Ramesh, any few last sentence from you, sir?
Yeah. So, the most important thing, both as far as for us, when we see patients with arthritis who don't fit into rheumatoid arthritis, is to look for all these discrete areas that you just mentioned, gluteal, atypical, post-auricular, navel, so on and so forth. And from a dermatology perspective, obviously the important few questions that I said, just ask those questions to the patient. And the final important thing is, I think there should be a shared care approach in managing patients with such complicated diseases. I cross-talk between dermatologists and rheumatologists is very important.
Thank you. Brijesh?
Yeah, what the take-home message of this entire thing is, the umbrella approach at screening your patient at the initial outset itself. Every case of psoriasis needs to be screened with the comorbidities in mind. Psoriasis is not skin deep, and you have to carry the systems along with it, because psoriasis is merely the fire. And it is not a fire which kills most, it is a smoke. which kills elastic cells. And the smoke is a comorbidity, that is psoriatic arthritis and cardiovascular risk. So that I think
Thank
should be
you.
a take-home message.
So before I wind up, I would like to just give, I don't know if I'm allowed to give a take-home message from my side. The only take-home message from my side I'm going to give is that this is an evolving field. We did recognize that there are comorbid conditions in psoriasis almost 12 to 14 years ago. But now we have started talking about modifying those comorbid conditions by using therapy. One of the tools that we have for therapy today is the biologic. Tomorrow the biologics may become innocent and they may get taken out of the market and better drugs become. Because progress, that's what progress means. But the point is, as of now, today, we have the biologics. And can we make a difference to comorbid conditions? And the most important comorbid conditions are cardiovascular and rheumatologic comorbid conditions because they adversely affect the duration and quality of life of the patient. And that is why we were fortunate enough to get Dr. Prakash and Dr. Ramesh Jois to share their thoughts with dermatologists like Dr. Brijesh and myself. So I think that more holistic approach needs to be taken up by dermatologists when they see their psoriasis patients. Dermatologists need to include cardiovascular risk scores. Dermatologists need to put in a questionnaire for joint disease and work closely with the cardiologist and also with the rheumatologist so that in case we find that there is an issue of a metabolic syndrome, your cardiologist is going to help you along the life of the patient. So while there is evidence for a biologic, let us not forget that it is this cooperation of all of us, that is the dermatologist, the cardiologist, the endocrinologist, the rheumatologist, everybody has to cooperate and make the patient's life better. One of the small tools that we have is the biologic, and if as time passes, I'm sure we'll get much better planned studies. In fact, the Cantos trial, which Dr. Brijesh referred to, uses canakinumab, which is a IL-1 blocker, not IL-17 blocker. So with the newer drugs coming up, I think we are going to get more answers in the future. So thank you very much for your presence, and thank you very much for my panelists for being with me and giving so much of valuable insight. I bid adieu after this. Thank you.
Thank you. Thank you, sir.
Thank you.
So there are a few questions in the chat box. If we can take one or two, will that be okay, Dr. Murli?
Chat box is will later, why delay? Thanks.
Okay. So yeah, we are quite late right now.
The delay is because you have delayed the onset of the seminar.
Okay, sorry for
You
that,
should
sir.
just see the chat box yourself.
Yes,
rather
sir.
than make me read it out.
I can read out few questions, sir, if we can take again.
Please do that.
So there is one question: can one biologic address all issues of psoriasis? Can we prevent comorbidities? Like if we are using only one biologic in spite of doing a combination therapy? The question is from Dr. Vinay Singh.
Brijesh, Dr. Brijesh, would you like to take that up?
In that particular scenario, I think the TNF inhibitors have shown much better evidence. I mean, if there is you're looking for one, but one biologic will not address everything. But TNF inhibitors, as far as the CV risk goes, I mean CV. I'm talking about cardiovascular risk. TNF inhibitors do score over other drugs. I hope I answer part of the question.
What about combining? There was another aspect of the question: combining biologics. So to my knowledge, that is not recommended and that is not done.
Okay, thank you, Dr. Murli. There is one other question, which is which biologic drug is best for palmoplantar psoriasis?
I personally found that when it comes to palmoplantar psoriasis, secukinumab is one of the most effective drugs when it comes to biologics. Having said that, it's not easy to treat palmoplantar psoriasis even with a biologic. Invariably, cases are very resistant to therapy.
Yeah,
And that,
yeah, here is one place where we might need to take the services of apremilast and tretinoin in addition to
combination
biologic.
therapy would be ideal there.
Ideal.
So there is one other question to Dr. Prakash. I think that will be the right person to answer. Do we have to look upon cardiovascular ASCVD score in severe psoriasis patients as a routine? ASCVD.
I think it's a must in all patients with severe psoriasis, but I also feel that forget ASCVD scores. Look at for the metabolic parameters. Look at the waist circumference. I mean, it's very obvious when you see the patient that he's got a pot belly.
No.
The thin, fat Indian. He may be thin otherwise, but he's got a big paunch which is coming out. Okay? And that paunch is where the atherosclerosis, diabetes, coronary artery disease, metabolic syndrome, everything starts and ends.
Yeah.
Okay? It's very simple. Just look at that paunch of that guy. And if he's got a big paunch, you need to look at him whether he's got mild, moderate, or severe psoriasis. Please understand, this is the bane of India.
Yeah.
We have got big paunches, the thin, fat Indians, as they're called.
Yes.
That's an Asian phenotype.
Yeah. Central obesity. Yeah. So there is one other question. I think this is open to whole panelists. So this is, would be nice to know number needed to treat of biologics for cardiovascular risk reduction. So what should be the number needed to treat?
I don't think that data exists, but Prakash can help.
Yes. I don't think. That's what the registry, that's why I made a comment initially, that a registry-based RCT, a large, simple trial within a registry, will be the only way to answer this particular question.
We don't have data to answer the question as of now. Yeah.
Longer follow-up.
Yes. So there's one question. What is the scope of having 3P MACE as endpoints in future long psoriasis trials? So 3P MACE as endpoint.
A 3-point MACE which is there is usually in large trials, and it cannot be statistically significant unless you have got a very, the same thing for NNT. You can't have it unless and until you have got a very large trial. So it's not going to be possible. It's 2% of the population, maybe 3.5% of the population, out of which 20% may be having disease. So it just comes to the point of a 0.4% of the population of the whole world. It's a too small a number for us to have a 3-point MACE or a 5-point MACE data. You cannot possibly have it. You'll have to just look into the matter as a registry.
Yeah, I think this answers the questions, Dr. Pallavi. The next question is from Dr. Prabhakar. TNF alpha inhibitor cause weight gain. Also, CI in CHF, your comment. Open to all the panelists.
All TNF alpha blockers produce weight gain. And this is not something new. It is important that every single psoriasis patient should be advised on lifestyle, and as Dr. Prakash pointed out, to make sure that pot belly doesn't come up. So unless and until you're going to manage the lifestyle of a patient, the TNF blocker also won't work. In fact, there are some studies where they have looked at responsiveness of TNF alpha blockers. Poor response is seen when the BMI is high. Poor response is seen when the wasted ratio is high. So it is absolute must to reduce that.
Okay, thank you, sir, for the answer.
And there was a particular question about heart failure also. TNF inhibitors are contraindicated currently in heart failure.
Yes.
Is 3 and 4 heart failure, but I think Dr. Murali has some difference of opinion regarding this. Yes,
there are some patients who have had early cardiac failure who actually responded to TNF blockers.
That is a grade 3 and 4 heart failure. Early cardiac. You still recommend absolute contraindication?
You are sitting in a OPD and you have a choice, avoid it.
Okay, thank you. So this question is more of on biologics and a comparative question. Is brodalumab better than other available IL-17 inhibitors like secukinumab and ixekizumab?
I'll take that. According to the See, we don't have practical experience with Brodalumab, but the Brodalumab blocks the receptors from IL-17A12. So it is certainly more effective. There's no doubt about it. It's much more effective. But having said that, IL-17B, C, D, and E hardly have much of a role in the pathogenesis of psoriasis. It is enough if you block 17A and 17F, which bevacizumab does.
Right. Okay. Thank you, sir. This question.
Because irrespective of the fact that the FDA has given the clearance for it, there definitely were suicides in the initial trial. And then after Valiant bought the company, the FDA reversed its decision. It tells us more about the US FDA than about the drug.
Right. Okay. So this question is open for all. Maybe Dr. Murali can answer this. This question is: does the presence of other comorbidities affect secukinumab therapy outcomes in psoriasis patients? Comorbidities in psoriasis and secukinumab as a treatment option.
I don't think that the presence of comorbidities, I am assuming that you mean comorbidities due to psoriasis. The comorbidities due to psoriasis are not affected, are not going to affect the efficacy of secukinumab. But if there is some other type of comorbidity, then I think we have to define what it is.
Right. Yes.
Like say, for example, inflammatory bowel disease, for example, you should not be using secukinumab.
Right.
And eternus.
So
there in the slide, which you guys deleted.
I think there is a technical glitch in that part.
We are now 2 hours into the panel. Any more questions?
Last question from Dr. Ramesh. It is focused on: does the presence of comorbidities affect the treatment choice and outcomes in biologics versus conventional DMARDs?
I think yes. I'm going to answer that yes.
Yes.
Yeah, yes.
If there is, let's say, for example, one of the comorbidities is NASH, I will never use methotrexate in NASH. I'm very clear about that. And the incidence of NASH in treatment-naive psoriasis patients is pretty high. There's a wonderful study published in Australasian Journal of Dermatology about 8 years ago, which actually quantified that patients who were not exposed to any drug, who had mild psoriasis, but had a little pot belly, had NASH also.
Right.
And just to add to that, demyelinating disorder, specifically a contraindication for TNF inhibitors. But this is a very, very loaded question, a very vast question, and we'll require another panel to discuss.
Try to have such discussions more on that. So we are done with the questions. So, yeah, Mona.
Thank you.
Yeah, thank you, sir. The post-poll questions could be projected so that the audience can actually answer those, so that we can actually get impact, like whether it was beneficial to the audience or not. And with this, I would like to give a thank you note for all the panelists and Dr. Murali for taking out time and giving us such impactful session. So thank you, Dr. Murali. I would like.
It's showing as 100.
So it is the poll question for the audience.
Yeah, okay. It will take some time.
So, yeah. So I would like to give thank you note for all the panel members, Dr. Murali for moderating the session. So also Dr. Brijesh Nair, who is currently working at Military Hospital Jaipur, Dr. Prakash Sanzgiri, who is HOD at Dr. Lilavati Hospital and Research Center, Dr. Ramesh Jois, consultant rheumatologist at Vikram Hospital, for joining this panel, giving us opportunity, and we can see that it is extended for 2 hours and it was for 1 hour. Thank you for giving us the time and taking up all the questions. We are really thankful to you. So any conclusive remarks, Dr. Murali?
No, I think everybody's had enough, right?
Yeah. Yeah.
Yes. Let's go for dinner.
So definitely a very broad prospect of looking on all the things, like how comorbidities are very important when we are going to treat psoriasis patients, how we have to look upon the patients, what other horizons we can look upon. So with this, I would like to thank all the audiences and conclude the meeting.
Thank you.
Thank you, everybody.
Thank you,
Thank you.
Ramesh.
Thank you.
And Brijesh, my friend. Thank you.